8 months. That is how long it took. From the first blurry morning to the appointment where the doctor said the words nobody wants to hear. The damage is permanent. The man sitting in that chair was 71 years old, a retired carpenter from outside Cincinnati. He did not drink, he did not smoke, he took his metformin every single day. He checked his blood sugar religiously. He did everything he was supposed to do. And still, diabetes ate his eyesight in 8 months. Now, here is what makes this story different from the thousands of diabetic vision loss cases I have reviewed. 3 ophthalmologists saw this man. 3. And all 3 of them missed the same thing. Not a tumor, not a detached retina, not glaucoma. They missed a vitamin deficiency. One vitamin sitting at the bottom of a standard blood panel that none of them ordered. A vitamin so cheap you can buy a 3-month supply at any pharmacy in America for less than the copay on one of those appointments. When his 4th doctor, not an ophthalmologist, not even an eye specialist, finally checked that level and corrected it, his vision started coming back. Not all of it, I need to be honest about that. Not all of it came back. But enough to read again, enough to drive to church, enough to see his grandchildren's faces clearly for the first time in over a year. So what I am going to do today is walk you through exactly what happened to this man, step by step. What went wrong inside his retinas. What the 3 doctors looked at and what they looked past. What the vitamin was, how it works, and how you can check whether the same thing is happening to you right now, silently, before you ever notice a symptom. Because that is the thing about diabetic eye damage. By the time your vision blurs, you have already lost tissue you are never getting back. Let us start at the beginning. His name, and I am using a composite here to protect privacy, but the medical details are real, pulled directly from published case literature. Let us call him Gerald. Gerald was diagnosed with type 2 diabetes at 63. Late onset, mild. His A1C at diagnosis was 7.1. Not great, not terrible. His primary care doctor started him on metformin, 500 milligrams twice a day, gave him a pamphlet about carbs, and said, "Come back in 3 months." He came back. A1C dropped to 6.8. The doctor said, "Good job, keep doing what you are doing." For the next 7 years, Gerald did exactly that. Took his metformin, watched his carbs mostly, walked 3 times a week, went to his checkups. His A1C bounced between 6.6 and 7.2, never spiked into emergency territory, never dropped low enough to cause concern, and then at 71, something changed. It started small. He noticed the newspaper looked different. Not blurry exactly, more like foggy, like reading through a window that had not been cleaned in a while. He figured it was age, got new reading glasses at the drugstore, the stronger ones, helped a little for about 3 weeks. Then one morning, and this is the detail he remembers most vividly, he was pouring coffee and missed the cup. Not because his hand was shaking, but because he could not see the rim clearly anymore. The edges of things were dissolving, like watercolors bleeding into each other. He described it to his daughter this way: "It is like looking through a wet windshield. Everything is there, but nothing is sharp." That was week 6. By week 8, he went to the grocery store and realized he could not read the nutrition labels. He was standing in the cereal aisle, holding a box of oatmeal, 6 inches from his face, squinting. A woman asked if he needed help. He said no. He put the box down. He left the store. He told his daughter later that was the moment he knew something was really wrong. Not because of the vision, but because of the shame. A man who built cabinets with his hands for 40 years, who could measure 1/8 of an inch by eye from across a workbench, could not read a cereal box. By week 10, he could not read his glucose monitor without holding it 4 inches from his face. The numbers were smeared. He started guessing his blood sugar. Think about how dangerous that is. By week 12, he asked his daughter to start writing his checks for him. He could not see the lines on the check. By week 16, he stopped driving voluntarily, handed his daughter the keys one Saturday morning without saying a word. She found them on the kitchen counter with a note that said, "You drive from now on." By week 20, he told his daughter he could not see her face from across the dinner table. They were eating pot roast, something she had made 100 times, and he looked up and said, "I can hear you talking, but I cannot tell if you are smiling." That sentence stayed with me, not the medical data, not the scans. That sentence, "I cannot tell if you are smiling." 8 months from a foggy newspaper to not seeing his daughter's face. Now, here is what happened medically during those 8 months, because this is where the story goes from sad to infuriating. Gerald saw his first ophthalmologist at week 8. Standard referral. The doctor did a dilated fundoscopic exam, looking at the back of the retina with a bright light. What he saw: microaneurysms, tiny balloon-like swellings in the retinal blood vessels, dot hemorrhages, specks of blood leaking from damaged capillaries, and early signs of macular edema, fluid building up in the central part of the retina, the part you use to read, to drive, to see faces. Diagnosis: non-proliferative diabetic retinopathy, moderate stage. Treatment plan: control your blood sugar better and come back in 4 months. That was it. Now, I need to be fair, that is a standard recommendation. It is not wrong. Glycemic control is the foundation of managing diabetic eye disease. But here is what that ophthalmologist did not do. He did not order blood work. He did not check vitamin levels. He did not ask about diet in any meaningful way. He looked at the eye, and only the eye. Gerald went home, tried harder with his diet, cut his carbs even more. His A1C actually came down to 6.5, the best it had been in years. His vision got worse. Week 14. Second ophthalmologist. Newer office, newer equipment, including an OCT machine that takes cross-section images of your retina. The scan showed what Gerald already knew. The macular edema had worsened. The damage was progressing despite the improved A1C. His blood sugar was better than it had been in 7 years, and his eyes were getting worse. That disconnect should have been a flashing red light, because in textbook diabetic retinopathy, when you improve blood sugar control, the eye disease stabilizes or improves. When it does not follow that pattern, it means something else is driving the damage, something the A1C improvement cannot fix. This doctor recommended anti-VEGF injections, a needle into the eye. It sounds brutal, and honestly, it is uncomfortable, but it is the current gold standard for diabetic macular edema. Gerald got 3 injections over 6 weeks, some improvement in the swelling, but his vision kept declining. That should have been another red flag. When anti-VEGF therapy is working properly, you should see stabilization within the first 3 treatments. When it does not work, it means something else is driving the damage. The second ophthalmologist said, "Sometimes these things take time. Let us try 3 more injections." Gerald got 3 more. No change. Third ophthalmologist, week 24, University Hospital. A retina specialist, the top of the food chain. He confirmed the diagnosis, agreed the injections should have worked better, suggested switching to a different medication, mentioned laser as a backup option. And still, nobody checked his blood. Not his vitamin D, not his B12, not his homocysteine, not any of the nutritional markers that published research sitting in the same medical journals these doctors read has directly linked to diabetic retinopathy. 3 ophthalmologists, 6 office visits, 9 injections into his eyeball, thousands of dollars. Nobody ordered a $30 vitamin panel. I do not say this to attack ophthalmologists. These are skilled, dedicated professionals. The problem is not incompetence. The problem is architecture. When you see an ophthalmologist for diabetic retinopathy, that doctor is operating inside a treatment algorithm, a flowchart. Step 1, diagnose the stage. Step 2, if mild, monitor. If moderate with macular edema, consider injections. If severe, treat aggressively. That is the flowchart. Nowhere on that flowchart does it say check nutritional status. Nowhere does it say order a vitamin D level. Nowhere does it say ask about metformin duration and B12 supplementation. It is not taught in ophthalmology residency. The published research sits in journals that ophthalmologists do not routinely read. There is a structural wall between the eye doctors and the metabolic doctors, between the people who look at the retina and the people who understand what feeds the retina, and the patient falls through the crack in between. Now let me show you what they should have been looking for. In 2003, a study was published in Nature Medicine, one of the most prestigious medical journals on Earth. The research showed that a fat-soluble form of vitamin B1, called benfotiamine, could block 3 of the major biochemical pathways that cause diabetic blood vessel damage. 3 pathways. One compound blocked all 3 simultaneously. Those 3 pathways are the rivers of destruction that high blood sugar uses to eat your blood vessels alive. Benfotiamine activated an enzyme that diverted the toxic sugar byproducts into harmless ones. In the animal model, benfotiamine prevented diabetic retinopathy entirely, published in Nature Medicine over 20 years ago. Let me explain why those 3 pathways matter. The first one, when blood sugar stays high, excess glucose gets shunted into a chemical process that changes how your retinal cells communicate and how your blood vessels regulate leaking. The second pathway creates advanced glycation end products, or AGEGs. These are like rust that forms on the inside of your blood vessels. It accumulates year after year, and it makes the vessel walls stiff, inflamed, and fragile. The third pathway controls blood flow to the retina. When it is overactivated, it constricts some vessels and dilates others in a pattern your retina was never designed to handle. 3 pathways, all fed by the same problem, and all blocked by one compound, benfotiamine. A 2009 study tested both thiamine and benfotiamine on human retinal cells. The study showed that benfotiamine completely prevented the death of those cells under high glucose conditions, not reduced, prevented, in human cells. And still, the large-scale trials that would change practice guidelines never materialized. Why? Benfotiamine is not patentable. It is a vitamin derivative. You can buy it at any pharmacy for about $12 for a 3-month supply. No pharmaceutical company is willing to spend millions on a clinical trial for a compound they cannot own exclusively. So the research sits, published in a top journal, cited over 800 times, but never adopted into clinical practice. Now here is the second piece. A 2017 meta-analysis of over 17,000 patients found that vitamin D deficiency was associated with double the risk of diabetic retinopathy. A more recent meta-analysis from 2025 confirmed it. In severely deficient patients, one study found that low vitamin D increased the risk of sight-threatening retinopathy by over 6 times. What does vitamin D do inside the retina? It suppresses a protein called VEGF, vascular endothelial growth factor. That is the exact same protein that those $2,000 eye injections are designed to block. Vitamin D suppresses VEGF from the inside, naturally, continuously, as long as your levels are adequate. I am not saying vitamin D replaces the injections, it does not, but when your vitamin D is sufficient, your retina is producing less VEGF on its own. The injections have less work to do. And then there is B12. This one should make you angry. Metformin, the most commonly prescribed diabetes medication in the world, depletes vitamin B12. This has been known for over 2 decades. A landmark 2010 trial in the British Medical Journal showed that metformin caused a significant, progressive decline in B12 levels that worsened with each year of use. Gerald had been on metformin for 7 years. When B12 drops, your body cannot properly recycle a compound called homocysteine. Homocysteine is a natural amino acid. At normal levels, it is harmless. But when B12 is depleted, homocysteine accumulates. Elevated homocysteine is a vascular poison. It directly damages the lining of blood vessels, it promotes oxidative stress, and it specifically damages retinal blood vessels. A 2011 study measured B vitamins and homocysteine in 300 type 2 diabetics. The patients with retinopathy had significantly lower B12 and significantly higher homocysteine than those without retinopathy. The association was independent of A1C, meaning even when blood sugar control was similar, the ones with low B12 and high homocysteine got the eye damage. Gerald's B12 was never checked by any of his 3 ophthalmologists. When his 4th doctor finally ran a comprehensive nutritional panel, Gerald's B12 was 189. Normal range starts at 200, but functional medicine practitioners consider anything below 400 suboptimal for neurological protection. His vitamin D was 14, severely deficient. His homocysteine was 18, elevated. Optimal is below 10. Do you see the picture? 3 deficiencies, all connected biochemically. all measurable with a simple blood draw, all directly implicated in published research in the progression of diabetic retinopathy. Gerald's functional medicine doctor put him on 3 things. First, methylcobalamin, the active form of B12, 5,000 micrograms daily, not the cheap synthetic form. Second, vitamin D3, 5,000 IU daily, with a fat-containing meal. Third, benfotiamine, 300 milligrams daily. Total cost, about $32 a month. Compare that to 9 anti-VEGF injections at roughly $1,500 each. Now, I want to be precise about what happened next. This is not a miracle story, this is biology. Over the next 8 weeks, Gerald's homocysteine dropped from 18 to 9. His vitamin D climbed from 14 to 41. His B12 went from 189 to 680. At his 12-week follow-up, the OCT scan showed a measurable reduction in macular thickness. The edema was receding, and Gerald could read the newspaper again. Not perfectly. The damage from those 8 months, some of that is permanent. Retinal tissue that dies does not regenerate, but the tissue that was swollen, compressed, oxygen-starved but not yet dead, that tissue responded. He could see the rim of his coffee cup. He could read his glucose monitor. He started driving again during daylight hours. His exact words to his daughter were, "I can see your face again. Now here is your action plan. This is not complicated, but you need to do it because waiting until you notice vision changes means damage has already occurred." Step 1. Ask for the blood tests nobody orders. Next time you see your doctor, ask for 5 specific tests. Write these down. 1. Serum vitamin D. You want to be above 30 nanograms per milliliter. Above 40 is better. Below 20 is the danger zone. 2. Serum B12. You want to be above 400. Lab ranges often start at 200, but that is not sufficient for a diabetic on metformin. 3. Serum homocysteine. Below 10 is optimal. Above 15 means your B vitamin status is inadequate. 4. Hemoglobin A1C. Below 7% is standard. Below 6.5 is better. 5. Fasting glucose paired with morning cortisol. This pair tells you what is happening overnight. If your doctor pushes back, just say this: "My blood sugar has been controlled, but I am concerned about microvascular complications. I would like to rule out nutritional contributors before they become irreversible." That language is specific enough to be hard to argue with. Step 2. If you are on metformin, assume your B12 is being depleted. This is not speculation. This is published consensus. If you have been on metformin for more than 2 years and have never supplemented B12, your levels are almost certainly suboptimal. Get methylcobalamin, not cyanocobalamin. The methyl form is active and ready to use. Take it sublingually, under the tongue, because that bypasses the gut absorption problems metformin causes. Dose is 1,000 to 5,000 micrograms daily. Step 3. Get your vitamin D above 40. If you are deficient, 5,000 IU daily is reasonable. Always take it with food that contains fat. Always add vitamin K2, 100 to 200 micrograms, to direct calcium toward your bones, not your arteries. After 90 days, retest and adjust. Step 4. Discuss benfotiamine with your doctor. Most doctors will not know what it is. Print the 2003 Nature Medicine study. The PubMed ID is 125924403. A reasonable starting dose is 300 milligrams daily. Step 5. Get a dilated eye exam every year. No excuses. Everything I just told you supplements standard care. It does not replace it. Before you go, 3 things you should not do. Number 1. Do not take high-dose B12 with certain acid reflux medications without your doctor knowing. Proton pump inhibitors like omeprazole impair B12 absorption through the same mechanism as metformin. If you are on both, use sublingual B12 to bypass the gut entirely. Number 2. Do not take high-dose vitamin D without checking your calcium and kidney function first. Vitamin D increases calcium absorption. If your kidneys are not filtering properly, you can run into trouble. Know your baseline. Number 3. Do not assume that supplementing vitamins makes blood sugar control optional. The vitamins protect the blood vessels, they fortify the retina. But if your A1C is sitting at 9 or 10, the flood of glucose will overwhelm any nutritional buffer, control your blood sugar, and optimize your nutrition. One without the other leaves you exposed. One more thing. Everything I showed you today covers what happens during the day, but for most people over 60, the real damage happens after you fall asleep. Between 2 and 4 in the morning, your liver releases glucose, your cortisol rises, and your blood vessels take a hit that nobody monitors. That is exactly what the midnight insulin trap was written for. It walks you through what changes after 60, why your morning numbers are high, even when you eat right, and a simple nighttime protocol. The link is below. Drop a comment. 3 words. Check my levels. I want to see how many of you have been on metformin for years and have never had your B12, vitamin D or homocysteine checked, not once. And if this helped you, share it with someone who has diabetes and is worried about their eyes. Because we cannot wait for the medical system to close this gap on its own. It has been 20 years since the benfotiamine study was published in Nature Medicine. 20 years. So we have to do it ourselves, one person at a time. Take care of yourselves. I will see you in the next one.